All right, nurses, we're going to talk about pulmonary function pathology in children. If my computer will behave. So the first thing we are going to discuss is this phenomenon known as croup. So croup is typically an infection of the larynx and the upper part of the airway. That infection of the larynx and the upper part of the airway tends to cause a barking cough. That kind of sounds like an angry seal. It's pretty common in kids, as shown here. Oh, 6 months to 5 years. That's usually when it's you see it the most. It's classically caused by parainfluenza virus, but it can also be caused by RSV, respiratory syncytial virus, adenovirus, and also influenza virus. There's a prodrome, usually of fever and nasal congestion, followed by this spasmodic barking cough that sounds like an angry sea lion, followed with a hoarse voice and inspiratory stridor. The severity of croup can be assessed using the Wesley Croup score. There are 5 different parameters, each of which gets 0 to 5 points, the top score being 25. The parameters include severity of the stridor, severity of chest wall retractions, severity of diminished air entry, the presence of cyanosis, and diminished level of consciousness. A Wesley Croup score of 2 or less is mild. A Wesley Croup score of 3 to 7 is moderate, and a Croup-Lee-West score of 8 to 11 is severe, and anything over 12 suggests imminent respiratory failure. Mild croup is treated in the home by giving antipyretics like acetaminophen, Tylenol, fluids, and providing the child cool, humidified air to breathe. Sometimes a single dose of oral steroids like dexamethasone can help reduce airway swelling. Children with moderate croup are treated in the emergency department with a single dose of oral dexamethasone along with inhaled racemic epinephrine. That reduces airway swelling and dilates the airways. If the child does not improve within 4 hours, then hospitalization is needed. Individuals with severe croup are usually hospitalized and treated with a single dose of oral, IV, or intramuscular dexamethasone, along with repeated doses of racemic epinephrine. If there is impending respiratory failure, then the child needs to be taken to the intensive care unit. A single dose of IV or IM dexamethasone is given with repeated doses of racemic epinephrine, and intubation is almost always done, especially if needed. Epiglottitis causes a very rapid onset high fever and sore throat and a kind of hot potato voice and severe respiratory distress. The child will often lean forward on their arms. That's called tripoding to keep their airway open. Lateral neck x-rays will show swelling of the epiglottis. That swelling is called the thumbprint sign. Acute epiglottitis was historically caused by Haemophilus influenza type B. Hib vaccination has greatly reduced that. Epiglottitis is a serious medical emergency, so intubation or tracheostomy is required right away. Once the airway is secure, then antibiotics are given, usually third-generation cephalosporins like ceftriaxone or cefotaxime together with vancomycin. Tonsillitis infections, if they are bacterial, usually occur without any nasal infection. So if the infection involves the tonsils and the pharynx, it's called tonsillopharyngitis. Viral tonsillopharyngitis causes a low-grade fever, sore throat, voice hoarseness, and symptoms of the common cold, like nasal congestion, conjunctivitis, and a cough. On physical exam, there's erythema and edema of the pharynx and the tonsils, but the tonsils usually don't show any exudates. There will also be non-tender anterior cervical lymphadenopathy. Bacterial tonsillitis is usually caused by Streptococcus pyogenes, most often, group A streptococci. There's usually a high-grade fever, sore throat, and voice hoarseness without the common cold syndromes. On physical exam, there's erythema and edema of the pharynx and tonsils, along with gray-white exudates covering the pharynx and tonsillar pillars, and tender anterior cervical lymphadenopathy. To identify strep throat, there is the so-called CENTOR criteria, CENTOR. This is a nice mnemonic. CENTOR starts with C. C stands for can't cough or an absence of cough. E is for exudates. N is for tender lymph nodes. T is for a temperature higher than 38 degrees centigrade. That's 100.4 degrees Fahrenheit for the uninitiated. OR is for age. Each criteria gets 1 point. For the last criteria, age, if the individual is between 3 and 14 years of age, they get 1 point. If they're between 15 and 44, they get 0 points. And if they're above 44, which is rare for strep throat, they get -1 point. If their combined score is -1, 0, or 1, the risk for strep throat is negligible, and it's most likely a viral infection requiring fluids and rest. If the score is 2 or 3, the risk of strep throat is slightly higher. So you can provide a rapid antigen detection test or a throat culture. If these are negative, then it's most likely a viral infection requiring fluids and rest. But if either of these are positive, strep throat's confirmed, and treatment is with penicillin V, amoxicillin, or cephalexin given for 10 days. If the center score is 4 or higher, the risk of strep throat is so high that antibiotic treatment is started immediately. Some cases of bacterial tonsillopharyngitis can develop into an abscess. In children over 10 years of age, it typically forms in the peritonsillar space and is called a peritonsillar abscess. In children under 10 years of age, it usually forms behind the posterior pharyngeal wall and is called a retropharyngeal abscess. In both situations, there's a high fever, drooling, dysphagia, that's difficulty swallowing, odynophagia, or painful chewing, and a muffled voice, and the person speaking as though they have a hot potato in their mouth. In a peritonsillar abscess, there's trismus, which is lockjaw, that's Trismus, while in a retropharyngeal abscess, there's a stiff neck with difficulty looking up, that's called torticollis, Torticollis. These can potentially cause dyspnea or stridor because they can block the airway. There'll be a very enlarged tonsil that shifts the uvula towards the opposite side. The retropharyngeal abscess will cause a bulge in the posterior pharyngeal wall. These have to be incised and drained and then treated with antibiotics, typically ampicillin with sulbactam, or amoxicillin with clavulanic acid, or clindamycin alone. Foreign bodies can either lodge in the upper respiratory tract or in the lower respiratory tract. So if there is partial airway obstruction due to foreign body aspiration, then there's coughing, gagging, choking, or drooling. On auscultation, there's inspiratory stridor. If there's complete obstruction, the child may be unable to cough or speak and even pass out, in which case you should start basic life-saving or BLS maneuvers to relieve obstruction. For infants less than 1 year of age, 5 back blows are delivered, followed by 5 chest thrusts. For children 1 year of age or older, 5 abdominal thrusts or Heimlich maneuvers should be performed. If the child is stable, a chest x-ray can be very helpful. Objects like coins or batteries are radio-opaque and are visible, whereas pieces of food are radiolucent and don't show up. In upper airway foreign body aspiration, you can do a neck radiograph. There'll be indirect signs of obstruction like subglottal densities or swellings. CT scans can also confirm the suspicion for foreign body aspiration. The child can be taken for laryngoscopy to visualize and remove the object. If an object gets lodged in the nose, then rhinorrhea or epistaxis, nose bleeding, will be present. And the body can be removed using headlamp and a nasal speculum. If there's complete lower respiratory obstruction, then you might get atelectasis. And if bronchoscopy cannot remove the object, then a thoracotomy might be required. Obstructive sleep apnea is suspected if the child has very large tonsils, and while the child sleeps, you hear a raspy breathing pattern. The child may also stir and wake up without them really knowing it. Sleep studies can confirm obstructive sleep apnea in children. This can cause daytime sleepiness if they have something like ADHD or something like that, attention deficit hyperactivity disorder, what have you. Daytime sleepiness can make such conditions a lot worse. And so a sleep study and tonsillectomies are usually the way you treat this. You can send the child to an ear, nose, and throat doctor, usually for this. Respiratory distress syndrome is due to inflammation of the interface between the alveolus and the capillaries. So this is usually a secondary condition. It can be due to a viral infection. In neonates, it's due to immaturity of the lungs, immaturity of the type 2 pneumocytes. So the child does not make enough surfactant, and that lack of surfactant can cause widespread atelectasis. Usually the child will need to be intubated with aerosolized corticosteroids to properly mature the lung in cases like this. And if this is not due to infection, then the prognosis usually is quite good for this condition. So as you can see, this can lead to respiratory failure. That's why getting the baby intubated soon after birth, if in fact the lungs are premature. And this is always a risk in a premature birth. So bronchopulmonary dysplasia is a chronic lung disease of the neonate that's caused by prolonged ventilation and is further defined by the age of prematurity, the extent of supplemental oxygen required, and diagnosis is based on prolonged need for oxygen supplementation and ventilatory support. Significant risk factors include prolonged mechanical ventilation, high concentrations of inspired oxygen, infection, chorioamnitis or sepsis, the degree of prematurity. Males are at higher risk for this than females. Intrauterine growth restriction, genetic susceptibility. There are lots of different things that can increase the risk of this. So bronchopulmonary dysplasia is considered if there's a prolonged need for supplemental oxygen in premature infants after 28 days of age or after 36 weeks post-menstrual age, and who do not have other conditions requiring oxygen like pneumonia, congenital heart disease, or something like that. Chest x-rays will usually show diffuse haziness due to accumulation of exudative fluid. Appearance will then, in the x-ray, will become multicystic or sponge-like with alternating areas of emphysema, pulmonary scarring, and atelectasis. Alveolar epithelium may slough, and macrophages and neutrophils and inflammatory mediators may be found in the tracheal aspirate. Prognosis varies with severity. Most infants gradually transition from mechanical ventilation to continuous positive airway pressure to low flow oxygen over the course of 2 to 4 months. Infants who depend on mechanical ventilation at 36 weeks gestation have a 20 to 30% mortality rate during infancy. Infants who develop pulmonary arterial hypertension are also at greater risk of mortality during the first year of life. Infants with bronchopulmonary dysplasia have a 3 to 4-fold increased rate of growth failure and neurodevelopmental problems. Infants also seem to be at an increased risk of developing asthma later in life, as well as lower respiratory infections, and may quickly develop respiratory decompensation if pulmonary respiration occurs. So treatment is nutritional supplement, also fluid restriction to prevent the pulmonary edema, diuretics to get rid of that extra fluid, oxygen supplementation is needed. And then because respiratory syncytial virus infections can be so deadly for these patients, they're given a prophylactic monoclonal antibody against RSV surface proteins called palivizumab, Palivizumab. Treatment is supportive. Weaning the baby from mechanical ventilation with supplemental oxygen should be accomplished as soon as possible. So respiratory infections in babies include, first of all, bronchiolitis. So bronchiolitis is usually viral in nature. So infections of the airways include acute bronchitis, where there's infection of the large bronchi, acute bronchiolitis, which affects the bronchioles, and then pneumonia, which affects the alveoli and the lung parenchyma. Acute bronchitis usually affects children under 2 years of age, and it's usually due to a viral infection. Most commonly influenza type A and B, parainfluenza virus infections, adenovirus infections, respiratory syncytial virus infections, or rhinovirus, or even coronavirus infections. Some bacteria that can cause acute bronchitis include Bordetella pertussis, the cause of whooping cough, Mycoplasma pneumoniae, and Chlamydia pneumoniae. They're usually symptoms of upper respiratory tract infection, like congestion, sore throat, occasionally low-grade fever. Key feature of acute bronchitis is a cough that lasts for more than 5 days. On auscultation, scattered rhonchi will be heard. If children have a cough that has a whooping sound to it or has lasted longer than 3 weeks, or are not vaccinated, then testing for pertussis is required. Mycoplasma pneumoniae and Chlamydia pneumoniae can cause acute bronchitis in older children and teenagers, but no testing or treatment is recommended. If a child is in respiratory distress, a chest x-ray can evaluate pneumonia, otherwise it's not needed. Treatment is rest in fluids that avoids triggers for inflammation, the biggest one being secondhand cigarette smoke. Antibiotics are generally not recommended, with the exception of pertussis, where a macrolide antibiotic is given, like azithromycin. Acute bronchiolitis affects kids between the ages of 2 and 6 months. Leading cause is RSV, but other causative viruses include adenovirus, human bocavirus, human metapneumovirus, and very rarely bacteria like Mycoplasma pneumoniae. Again, there are symptoms of upper respiratory tract infection like congestion, sore throat, cough, occasionally low-grade fever. But the key feature is that acute bronchiolitis leads to respiratory distress. Signs of moderate to severe respiratory distress include a respiratory rate over 70 breaths per minute for infants younger than 12 months of age, and over 50 breaths per minute in older children, oxygen saturation below 92%, nasal flaring, intercostal, subcostal, or suprasternal retractions, or cyanosis. The child might also have difficulty feeding or appear lethargic or dehydrated. Some children can even have brief apneic episodes. Bronchiolitis is particularly severe among infants that were born prematurely, are younger than 12 weeks old, had a low birth weight, did not breastfeed, or have chronic pulmonary disease, are hemodynamically significant congenital heart disease, immunodeficiencies, or a neurological disease that impairs sputum clearance. There are rapid antigen tests to look for RSV. Treatment is focused on rest, IV fluids, and respiratory support. Supplemental oxygen can be given via a nasal cannula, a face mask, or a head box to maintain an SpO2 above 92%. And it's important to avoid secondhand smoke, just like with acute bronchitis. In severe cases, if the child is infected with RSV, ribavirin, an anti-RSV antiviral medication, may very well be used. And for prophylaxis, you can use the pelivizumab. For bacterial pneumonias, early onset neonatal pneumonia occurs in the first 3 days of life. The most common pathogens are group B streptococci, E. coli, and Listeria monocytogenes, an organism that's passed from mother to baby through the placenta. Late onset neonatal pneumonia, which develops from the 3rd day of life to the 3rd week of life. The most common pathogens are Streptococcus pneumoniae, Staphylococcus aureus, and Streptococcus pyogenes, as well as viruses like adenovirus, parainfluenza virus, influenza, and enteroviruses. From 3 weeks until 6 months of age, the most common pathogens are, again, viruses, with RSV being the most common, followed by parainfluenza and adenovirus, followed by the bacteria, Streptococcus pneumoniae, Bordetella pertussis, and Chlamydia trachomatis, which can cause afebrile pneumonia of infancy. From 6 months to 5 years of age, the most common cause of pneumonia are still viruses: RSV, influenza type A and B, parainfluenza, and human metapneumovirus. Less commonly, bacteria, Streptococcus pneumoniae, Staphylococcus aureus, but also Haemophilus influenzae. Less commonly, atypical bacteria like Mycoplasma pneumoniae and Chlamydia pneumoniae. In kids over 5 years of age, typical bacterial causes become most common that cause diffuse pneumonia, that's Mycoplasma pneumoniae and Chlamydia pneumoniae, while Streptococcus pneumoniae is the leading cause of consolidated pneumonia. Kids exposed to sick family members and have the symptoms of tuberculosis should be tested for tuberculosis. Children with exposure to farm animals might have Q fever caused by Coxiella burnetii. Children with exposure to birds like parrots and pigeons might have pneumonia caused by Chlamydia cetacei. Children exposed to mouse droppings might develop hantavirus pneumonia. Children with T-cell deficiencies and living in specific geographic areas might have fungal pneumonias. Newborns and infants with pneumonia will have fever, poor feeding, lethargy, sometimes apnea. Older children classically will have fever, cough, and tachypnea. Symptoms vary slightly depending on the pathogen. In bacterial pneumonia, symptoms usually start suddenly and are more severe, and there usually are not upper airway symptoms. Viral pneumonias typically begin more gradually, are more mild, and usually there are upper airway symptoms, and atypical pneumonias fall somewhere in between. Bacterial pneumonias have focal bronchial breath sounds or crackles, while viral and atypical pneumonias have diffuse bilaterally auscultatory findings. Wheezing is common in viral and atypical pneumonias, not in bacterial pneumonias. If the pneumonia causes mild symptoms, chest X-rays are not routinely done. Severe pneumonia is defined as having a fever greater than or equal to 38.5 degrees centigrade. Moderate to severe respiratory distress or hypoxemia with an oxygen saturation lower than 90%. And it's also severe if the infant has difficulty breathing or is dehydrated. In severe pneumonia, chest X-ray is always done and will show lobar consolidation or a diffuse interstitial infiltrate. There can also be complications. You can have lung access, atelectasis, and so on and so forth. Aspiration pneumonias occur if the child is being intubated. These type of pneumonias can be very severe, and it's important to make sure that the child is properly having their secretions removed and also they're being fed properly. Meconium aspiration syndrome is a respiratory condition caused by aspiration of amniotic fluid contaminated by fetal stool before or during birth. The stool will have biopigments. The meconium will have a black-green color. Meconium aspiration syndrome occurs in approximately 10% of neonates exposed to their meconium. The meconium will be in their airways. There'll be airway obstruction leading to atelectasis. Surfactant deactivation and the synthesis of surfactant will cease. You'll have a chemical pneumonitis because the meconium irritates the airways. This can lead to persistent pulmonary hypertension of the newborn, causing hypertrophy of pulmonary vessels due to chronic distress, and it also provides a medium for bacterial growth, increasing the risk of infection. It's caused by fetal distress due to perinatal complications of things like maternal hypertension, preeclampsia, placental insufficiency, oligohydramnios, decreased amniotic fluid, perinatal infection, perinatal acidosis, maternal drug use. Fetal hypoxia increases vagal nerve stimulation. That increases gastric tract peristalsis and sphincter relaxation, increasing meconium release. Hypoxia also causes fetal gasping and aspiration of the meconium-stained amniotic fluid. Complications include pneumothorax, pulmonary hypertension, neonatal infection, infant respiratory distress syndrome, and infant acidosis. The kid will have a low APGAR score. There'll be meconium spotting during labor. There'll be green-yellow color of amniotic fluid. There'll be respiratory distress, labored breathing, tachypnea, bradycardia, intercostal, subcostal, substernal retractions, nasal flaring, cyanosis. Blood gases will show hypoxemia, hypercarbia, acidosis. There'll be low oxygen saturation, crackles, rhonchi. The treatment is with antibiotics. You maintain proper circulatory volume, correct existing metabolic imbalances, transfer the kid to the NICU. You can use intrauterine saline infusions. If the meconium-stained amniotic fluid is present, that's a preventative measure. That dilutes the meconium, prevents the risk of aspiration. You want to maintain oxygenation and ventilation. You want a neutral thermal environment and supplemental oxygen, mechanical ventilation if necessary. If you have persistent pulmonary hypertension of the newborn, you can give the baby inhaled nitric oxide and phosphoesterase inhibitors like cytostazole and things like that. If severe, you'll have to use extracorporeal membrane oxygenation or ECMO. Bronchiolitis obliterans is typically seen in industrial asthma situations where you have the inhalation of anhydrous ammonia or something like that. This, however, is a condition in the newborn where you have immaturity of the airways. The type 2 pneumocytes don't make enough surfactant, so the lungs collapse upon inhalation. If you intubate the baby properly and you provide good aerosolized corticosteroids, then prognosis is usually quite good. This is usually recognized quite early. Because usually you'll have this respiratory distress upon birth. There'll be tachypnea, tachycardia. Again, the substernal, subcostal, intercostal retraction, cyanosis, nasal flaring, expiratory grunting. And this is just due to increased surface tension in the lung and decreased lung compliance because of surfactant deficiency. You have alveoli collapse upon expiration. That's called microatelectasis. You'll have a ventilatory perfusion mismatch. It'll cause interpulmonary shunting and hypoxemia. So asthma is a non-infective inflammation of the airways. This will cause bronchoconstriction, hyperproduction of mucus that can block the airways. Triggers for asthma include allergens like house dust mites, animal dander, and pollen, irritants like tobacco smoke, respiratory tract infections, cold or dry air, even emotional stress, or even exercise. In response to triggers, there will be symptoms like dry cough, chest tightness, or shortness of breath. On auscultation, there'll be wheezing during expiration. That wheezing is heard over both lungs. There'll be, if you do pulmonary function tests, there's decreased ratio of FEV1 to FVC during an asthmatic episode. Chest x-ray is usually normal, but it might show hyperlucency due to air trapping and hyperinflation of the lungs. A CBC might show increased eosinophils and increased IgE levels. Skin testing might show specific sensitivity to allergens. It should be avoided. Medications might include a short-acting beta-2 agonist. If the asthma gets worse, then you step that up to long-acting beta agonist combined with an inhaled oral corticosteroid. Severe asthma may require oral corticosteroids. In severe asthma exacerbations, initial treatment includes nebulized bronchodilators like albuterol and ipratropium, as well as systemic corticosteroids. Which of the following is true regarding asthma in children? The answer is C. It's the most prevalent chronic disease in childhood. So acute respiratory distress syndrome, ARDS, is a condition where there's inflammation throughout the lungs leading to pulmonary edema. The main site of injury is the alveolar capillary membrane. Damage to the alveolar epithelium or the capillary endothelium increases permeability of the alveolar capillary membrane, causing fluid to move into the alveoli. Oxygen and carbon dioxide have to travel across this fluid, so it acts as a barrier against normal gas exchange. The fluid also dilutes out the surfactant molecules that coat the alveoli. As a result, the alveolar walls become less able to remain open and compliant, so they become stiff. And as the injury continues, the alveoli eventually collapse. ARDS is not a primary lung disease. It arises as a complication of systemic injury that causes widespread inflammation, which results in damage to the alveolar capillary membranes within the lung. Most common underlying systemic cause of ARDS is sepsis, which causes systemic inflammation in response to an infection. Other insults can include things like trauma, severe burns, near drowning, DIC, acute pancreatitis, massive blood transfusions, aspiration of gastric contents, inhalation of toxic smoke, blah, blah, blah. Individuals with ARDS are very sick. They have severe shortness of breath, tachypnea, hypoxemia, diffuse crackles on auscultation of the chest. So it's important to look for an underlying cause, pneumonia, urinary tract infections, infected PICC line, whatever. There are 3 different criteria for ARDS. Symptoms develop within 1 week of the suspected infection or injury. Chest x-ray will show diffuse bilateral opacities. The symptoms are not explained by congestive heart failure. And then the ratio of partial pressure of oxygen in the arteries to the fraction of inspired air is less than 300 torr, 300 millimeters of mercury. First 2 criteria are pretty straightforward. The last one requires these lung tests. If the patient has sepsis, you treat with antibiotics. In ARDS, the alveoli are quite fragile, so positive pressure that comes with mechanical ventilation can overdistend the alveoli and worsen the ARDS. So you have to use so-called lung protective ventilation. This gives the alveoli low tidal volume that doesn't overdistend the alveoli. Prone position ventilation seems to improve ventilation the best in cases like this. Cystic fibrosis is an autosomal recessive disorder in which there is a mutant cystic fibrosis transmembrane conductance regulator, which is mercifully abbreviated CFTR. The mutant CFTR protein causes secretions to be abnormally thick and sticky, and these secretions build up in the lungs, pancreas, and other organ systems. The CFTR protein is a chloride channel that pumps chloride ions into various secretions. Chloride draws water into those secretions, and that helps thin out the secretions. Most common mutation that leads to cystic fibrosis is the so-called F508 mutation, where the phenylalanine number 508 is missing, and that causes the CFTR protein to not fold properly and not make it to the cell membrane. So without the CFTR protein, without functional CFTR protein on the epithelial surface, you don't get proper chloride ion pumping into these secretions. So diagnosis of cystic fibrosis is done with newborn screening. You can detect a pancreatic enzyme called immunoreactive trypsin, or ITR, in the blood. And that gets released into the blood when there's pancreatic damage from cystic fibrosis. Another confirmatory test is the sweat test, otherwise referred to as the quantitative pilocarpine odontophoresis test. Yeah, I like the sweat test better. That's shorter. Cystic fibrosis patients sweat enormous amounts of chloride. So in the lungs and pancreas, the mutant CFTR protein cannot pump chloride into the secretions, but in sweat glands, the mutant CFTR protein can't pump chloride from the sweat. So sweat level, chloride sweat levels are very high. They're over 60 millimoles per liter. Also, there's DNA testing, and that can confirm the presence of cystic fibrosis mutations as well. In the newborn, these thick secretions can affect the baby's meconium, or first stool. The meconium gets so sticky, it gets stuck in the baby's intestines, and it causes small bowel obstruction. This is called meconium ileus. And if the baby doesn't pass the meconium within the first day of life, this can cause bilious vomiting and abdominal distension. A rectal exam reveals an empty rectum with no meconium, but with normal anal sphincter tone. Meconium ileus is a surgical emergency because it can cause bowel perforation and peritonitis, and that can lead to septic shock, which can cause organ failure and death. If a baby is septic, then the vital signs usually include temperature instability, fever or hypothermia, tachycardia, tachypnea, and hypotension. And the baby will have a distended, rigid abdomen, and the baby will look mottled and lethargic. Abdominal x-rays can show a dilated bowel loop with air fluid levels proximal to the obstruction, along with a soap bubble or ground glass appearance at the site of the obstruction due to small air bubbles mixed in with the meconium. Treatment requires decompression of the GI tract through a nasal gastric tube while giving IV fluids. And if there's no perforation or peritonitis, then a hypertonic contrast enema is given to break up the meconium. And if that doesn't work, or if there's perforation and peritonitis, surgery is required. Pancreatic insufficiency is common because the thick secretions jam up the pancreatic ducts. That prevents digestive enzymes from making it into the small intestine. Without those digestive enzymes, fat is not properly absorbed, causing steatorrhea or fat-containing stools. Over time, this can lead to poor weight gain and failure to thrive. The backed up digestive enzymes also degrade the cells that line the pancreatic ductal systems, causing acute pancreatitis. Or if there are repeated episodes, chronic pancreatitis, diagnosis is made when the levels of elastase, a pancreatic enzyme in the stool, is above 200 micrograms per gram of stool. Sorry, if the elastase is below 200 micrograms per gram of stool. If the levels are that low, then children are given extra calories to supplement their diet with fat-soluble vitamins, and then pancreatic enzyme replacement therapy, or PERT, which contains enzymes like lipase, amylase, and protease. And this can also cause, the destruction of the pancreas can cause type 1 diabetes. That's why kids starting at the age of 10 get screened for diabetes. Lung damage can also occur because the lungs get filled up with this thick mucus. The lungs can become colonized with bacteria. The chronic bacterial infection inflammation can lead to bronchiectasis. This can also erode blood vessels. You can get coughs with sputum, that's hemoptysis. Pulmonary function tests will show an obstructive pattern, meaning a decrease in the forced expiratory volume. Chest x-rays will show normal or mild hyperinflation with flattening of the diaphragm. Clearing out the mucus can help with breathing. To do this, you use bronchodilators. You can also use nebulized N-acetylcysteine. That helps break up mucus, as does Dornase alpha, which degrades DNA found in mucus that will tend to bulk it up. And then inhaled or oral glucocorticoids can suppress inflammation. Antibiotics can deal with the infection. There are drugs also for certain mutant forms of the CFTR protein. Drugs like ivacaftor, tezacaftor, lumacaftor, these bind to the mutant CFTR protein and they help it fold properly. And so you now have functional protein at the membrane. To do this, you need to do CFTR genotyping. And that's cystic fibrosis. Sudden infant death syndrome is what causes it is completely unknown. You have an unexplainable death of the infant less than 1 year of age, despite thorough death scene investigation, analysis of perinatal history, and an autopsy. The present model is that there are 3 triggers. Sleeping prone or an infection that trigger. There's some underlying vulnerability. What that is unclear. Genetic polymorphisms that involve the autonomic nervous system, cardiac conduction systems, altered cerebral serotonin signaling. There's some sort of developmental vulnerability because of immature neuroregulation of cardiorespiratory control, delayed immune functionality. Risk factors for SIDS include previous loss of an infant from SIDS, if the parents smoke or abuse substances, teenage pregnancy, inadequate prenatal care, low prenatal birth, premature birth, intrauterine growth restriction. Male babies are more prone to SIDS than female babies. The strongest modifiable risk factor is sleeping in the prone position, soft sleeping surfaces, loose blankets or pillows, stuffed toys, overheating, or bed sharing. Signs and symptoms are just the infant gets put to bed without sign of distress, and then they're found unresponsive. So it's a diagnosis of exclusion. Protective factors include prone sleeping position, elimination of environmental risk factors. Breastfed babies are less likely to die of SIDS. Room sharing with the parents, but not bed sharing. And then, of course, immunizations. Unimmunized babies are much more prone to SIDS than immunized babies. So children born prematurely require respiratory support. Which of the following is most likely diagnosis? The answer is D. Chronic lung disease of infancy, the term used for persisting lung disease following neonatal lung injury. That's chapter 28.